welcome back to another edition of the Physiotutors podcast. Today we have with us Katie Mitchell. Katie Mitchell is the owner of Thrive Neuro-Sport. Katie also has currently doing her PhD, finishing off her data collection, and works with para athletes. And Katie, look, that's a very brief 30-second intro to yourself. Why don't you take 1-2 minutes and just introduce yourself to the audience, and then we're going to go from there. And maybe a little bit about what the PhD includes.
Awesome. Thank you so much for a very brief introduction. So I am clinically, by trade, I am a registered physiotherapist and certified athletic therapist. And so I kind of initially started in the trenches of working with sports teams directly on the bench or on the sideline, sort of rugby and ice hockey as well in the clinic, obviously. And then sort of built up my research interests over time while working in kind of private practice, orthopedic clinics and sports medicine. As sort of the concussion interest started to build kind of in the early 2010s there. And so I ended up asking so many questions that I decided to pursue my own research through a doctoral degree. And so I started at Wilfrid Laurier University in 2016 with that. And kind of since then have built up my dissertation looking at athletes with and without history of concussion and sort of influences of sport competition factors. So looking at things like visual attention and perception, integrated with like dual tasking and balance control, and even exertion and the effects of kind of that autonomic system regulation on those other factors. So we sort of look at like these late phase assessments and compare sort of the normative values of athletes without concussion to athletes with a history of concussion. And needless to say, it's been an interesting process through kind of rolling lockdowns in our province in Canada with the COVID-19 pandemic. So it's been a little more extended than planned, but I'm hopefully rounding up my data collection soon. And those studies are all with sort of collegiate varsity team athletes, and including, like I said, rugby, ice hockey. In Canada, we have lacrosse and a couple other team sports like American football. So a lot more like the tactile athletes. I've translated that nicely into my practice, Thrive Neuro-Sport, connecting kind of the brain and body together to like regain function and also perform in sport and life. So as we were talking about earlier, just the idea that you can't really tease apart the brain and the body, even though we are kind of learned or sort of taught that way in school with sort of learning things in silos of like neuro rehab, orthopedic rehab, cardiorespiratory rehab. Things are very much integrated and complex. And so I've really opened up my perspectives in the last few years and started to begin teaching other clinicians as well. So it's been a really fun journey.
Fantastic. Nice. I think that brings us nicely onto one of the reasons that I messaged you in the first instance. One of the reasons why I wanted to get you on is that combination of the neuroscience aspect coming into the rehabilitation that you do with your athletes, because it's not just with athletes with neurological conditions that you're doing this with. It's not just athletes that have concussions that you're doing this with, or who may be paraplegics or what have you. You're doing this with your everyday musculoskeletal patient client as well. How is it that you utilize that in your day-to-day runnings with the clinic or with your patients? And why is it that you've taken that approach as well, as it's not something that, again, we're taught that heavily in school, the impact of the neurological system on musculoskeletal rehabilitation?
Yeah, exactly. And so I think through the years, I always had this really strong interest in neuroscience, but yet I was like on the bench or on the sideline working directly with teams during gameplay and doing like first responder stuff as well as clinic. And so I'd see injuries, but then I could never really fully explain like what I was observing sometimes. And, you know, it was that gap between the clinic and then sport competition and meeting those demands. And if you think of what the demands of a sport competition are, it's sort of this chaos, like chaotic environment with this like sort of constantly evolving dynamic, like visual field, attending to various things, having to then to make quick decisions to perform actions successfully, not just an action, but actually choosing the right call or maybe making a last minute change in that action. So there's a lot of like neurological processing that goes on as we interpret our surroundings. And so when you think of like how we originally taught kind of the traditional approach of like, doing an exercise, very controlled, very like low sensory stimulation with it, you're very focused on the biomechanics. But when it comes to like motor control, and as I got into my PhD work, I started reading all these like fundamental papers about sort of the ecological approaches to motor control of like basically interpreting environments, taking kind of the options or affordances in those environments, and then deciding to perform actions based on what our capabilities are. And so if you think of it that way, when like even someone's just walking down the street, they have to interpret the environment around them to make a successful action to navigate that sidewalk, for example. So like say a branch falls on the sidewalk, they now have to adapt their gait to get over that, but it's all dependent on their range of motion, their stability or balance control. It's the dynamic components of even like the strength, and they step over it or they have to go around it. What else visually is going on if there's another person approaching them. So those are all things that we encounter day to day. It's never a predictable environment, unless you're in the comfort of your own home. But most often than not, the injuries that occur are things that, especially in sport, are in those unpredictable or chaotic environments. And so to kind of translate that into musculoskeletal injuries, so seeing it as it started kind of with my work with concussion, so I started seeing it with like, say, an ankle sprain or maybe an ACL tear or a hip injury. For example, say like an athlete with a groin strain or something. So if we're working on like building them up to maybe cutting and pivoting for sport performance, it's like, do we add a component of randomness with visual cueing or other stimulus in the space to cause like reactive kind of functional movements, rather than just these really predictable movements of instructing them to move this way, move that way, or a predictable pattern? It's like maybe they have to actually interpret the environment with the cues that they're given and let the movement evolve on its own. And so that's kind of the sort of the J.J. Gibson approach of sort of the like perception action integration idea with the ecological approach of like what we perceive then allows us to create actions, but those actions also create new perceptual information of our like vision, vestibular, our proprioceptive information. So to kind of allow movement to constantly evolve like that and is more like dynamic and reactive to an environment, engages those sensory variables. And so that's kind of how this like Neuro-Sport idea, and I can't say I created that whole concept. It was existing before, but when I tried to describe what I do to people, it was very difficult to tease them apart. And so I decided to, like when I decided to name the clinic, I used Neuro-Sport as sort of the description in that.
Fantastic. Now, it kind of sounds like there that you're creating tasks that have multiple layers, multiple levels to them. It's not just as simple as the agility T kind of go from one cone to the next cone, back to previous cone, what have you. It's more so built up to every movement that you're going to make, there's going to have consequential actions that are going to require consequences, and then you're going to have to then move and adapt to whatever part B of the task is going to be. Would that be a fair summation? Very
that's like a part of it. I always think of it as kind of like an onion with it, whereas like say if you're using that like a T drill like that, also considering like what is incorporated into a T drill and why an athlete might struggle with it, especially with concussion recovery, for example. There's like quick whole body rotations with engaging the vestibular system. There's visual motion of them moving in space with that. There's also the information from their body that their cerebellum has to use for the like rhythm to the pattern of the drill. So there's lots of various things that like the brain does contribute to that drill, which I feel like we're also, again, like not taught that perspective on it. So yes, you can add random components in, but even just learning that pattern, there's a lot of other like sensory stimulus there.
Yeah. So that's where I was going to get to, of you have this very basic idea of the T. And then if you have someone with an ankle sprain or someone with an ACL tear that is either on the conservative approach or on a post-operative approach, their mechanisms for then making those turns that you mentioned are going to be completely different to then if we add a third person into that who has that concussion element. So they're going to have more central disturbances in their ability to navigate, whereas the person with the ankle sprain is going to have this peripheral issue in their ability to navigate the task. Now, even if we don't layer up the task too heavily in terms of adding in, let's just say, a water bag to perturb their movement, or they're going to have to do it with a 5 kilo weight in their hands or a kettlebell or 4 kilo kettlebell, just to upset their balance and their movement. Even if we're not layering it up like that, there's different ways in which their body is going to adapt or react to even making a turn to the left if they've got a right-sided ACL issue, and they're going to have to turn to the right. They might, even if they're right-footed, make that turn with their left because their body, even though naturally prior to the injury they would have gone to the right with their right leg, they're going to make this adaptation. So this is something where you would come in to help tease them back into their shall we say, natural way of working. And again, this is just the peripheral aspect. How is it that this isn't something that is picked up and taught in school? Like, because it doesn't seem straightforward. And I'm sure someone will have to listen to that back a couple of times if they're not as familiar with what we're going on about here. But the fact that we have these compensatory mechanisms within our bodies without even realizing that we're making them is almost unfathomable that our body does this without us knowing, right?
Yeah, for sure. That's a really good point that you made, especially with adding different variables. And really, like, when I've started to kind of think of myself as a scientist over the last couple of years as I get into this stuff as this clinician scientist, and I'm like really nerdy about when it comes to things like variables and how do you manipulate those variables. So whether it is any of those components of clinical domains of whether you add kind of upregulate proprioception by adding some weight, maybe you change the way they use their vision by using cues. So maybe you have sort of like one of the examples would be like something like an LED light stimulus, like a fit light trainer or a blaze pod style light, where it's actually cueing them to go to those locations. Those are ways that, say, for example, if it's a musculoskeletal condition, that is, we talked about this peripheral versus central mechanism or injury or dysfunction, typically it comes down to the communication. So it's like, how can we upregulate and improve the communication of the brain and the body? So if someone's sort of body awareness or the mechanisms that they're using is kind of protective, or it's causing them to compensate in ways with their movement to protect an area, it's like, how can we kind of distract them from that? So using something like a visual cue in that instance works really well, because now they're just focused on getting to their goal. And we create this goal-oriented approach rather than them thinking, oh no, I got to cut this way and go that way. It's like they're just trying to get as quickly as they can. And then that movement naturally evolves without them being sort of internalizing about the movement process itself, or the cueing of saying, like, the clinicians saying, make sure you don't move that way, move this way. It's like, okay, now they have to think about, oh, now I have to do that, but how do I do that? And they feel sort of, discombobulated about it until they pick up the pattern. But it's like, if we can just cue the pattern, whether it's, I use even simple DIY apps, like Switched On Training is one of my favorite apps for that. And you can program things like arrows or numbers or colors, and you could just cue it up to sort of your own, your structure of your format with what equipment you have. But stuff like that is the difference of with a concussion. Sometimes we upregulate the proprioception side because vision and vestibular are sort of miscommunicating at the central sort of sensory location, if we call it that, of where those are primarily processed. So things like I would add like ankle weights maybe to someone who's trying to struggles with balance and coordination, because it upregulates the grounding of their feet. Similar to what we've seen with research from compression vests or something, where it kind of gives them more feedback, so that helps with vestibular and sort of that visual vestibular connection. So yeah, it's kind of like taking sort of these principles, even some of strength and conditioning I pull in, and like these kind of, we're talking about an agility drill, but like the neurological aspects of that agility drill. So my goal is a lot of for the athletes I work with, of whatever injury or condition they have, is to get them to that, either returning to the gym with their strength and conditioning coach or returning to their full competition level. So we're considering things like the level of exertion and intensity, the duration of time that they're performing that for. So say if I had a fit like drill set up, I might do like mimic sort of like a 1 minute shift, for example, of that agility to ensure that they can handle that.
Yeah.
And so when we look at interventions like kind of clearance, it's like we're basically collapsing the silos altogether, and even adding in some of those cognitive pieces or challenges sort of encourage the decision-making process as well when it comes to that type of cueing and then response.
Grand. I want to come back to the different stimuli that you're potentially going to get, because also when you get someone back onto field, they're not going to be in a relatively quiet practice, or even if it's a gym that has a fair bit going on, their attention is focused on what's going on in front of them with their therapist and the task at hand. They don't have to worry about other players on the field, which obviously in something such as ice hockey or rugby or football, you get people coming at you with some speed, ready to knock your block off. So you can't just focus on the ball. There's a couple other things going on, but then there's also the auditory things that are going on, other visual stimulus that's going on, which I think is fascinating with the concussion side of the rehabilitation. But if before we go that far into it, what is it that you do for your assessment? Because I think most everybody listening to this will understand the basics of musculoskeletal assessment for a knee injury or an ankle injury. How is it that you go this step further in assessing their neurological competency, if we can say it, if we can put it like that? It's probably not the best word to use, but yeah.
That's an interesting way to put it, if I can use words. So yeah, I think it comes down to, for most like MSK assessments, I would say it's not terribly different. Sometimes I will look at things, especially if an athlete's been off sport for a long time during the recovery. I'll look at things like, especially if they have a concussion history, which is not uncommon from a musculoskeletal return standpoint, of looking at sort of just basic vestibular ocular function, and go through some of those screening tools, like even the vestibular ocular motor screen or something like that, where I just quickly look at eye movements, balance control for lower extremity. I use force plate analysis in my clinic. I've tried to translate a lot of the tools that I have in my lab to my practice, which I wouldn't say is the cheapest thing to choose to do, but it helps from a standpoint of evaluating those sensory variables from in standing, for one. We'll also look at functional response time. So say like a drop jump with a cued like change in direction. So like there's a study by Landon Lemke that looked at, was specifically more concussion, but functional response time tasks is just a quick drop jump to a lateral bound, which could be queued up from one of the fit lights, and I can get reaction time from those. So I do quantify some of these things, and also just subjectively evaluate it as well, of maintaining biomechanics, coordination, dual tasking, and it's another way to look at things. So just even like another common one, especially with concussion, would be like tandem gait with, counting backwards from 6s or 7s, or incorporating head rotations with it, and then looking at the person's ability to maintain balance control, or just maintain like fluid movement and do two things at once. I've done that with older adults with arthritis, of just seeing if they can walk and kind of talk to me at the same time, which is actually surprising of how many cannot. With given a specific task to do, is that dual task. So certainly like more on the concussion side is what I kind of specialize in, but there are components that I will sort of tag into the MSK and ortho side as well.
Okay. You mentioned the use of force plates and a couple other bits and bobs that are maybe specialist pieces of equipment. What could someone utilize without having too much extra kit in order to conduct even a rudimentary neurological assessment for people? What kind of tools could they maybe take into clinic? As I know here in the Netherlands, if I was to go to the clinic I used to work at and ask them for force plates, it might take a couple of years for them to scrounge a bit of budget together to consider talking to me about it.
Yeah, I don't know who else even in my province has one. So I think it's kind of rare, not like to the degree of which I have one. I know people have like vertical ones that are, more commercialized, but I have a laboratory grade one for more balance related tasks, and hoping to get a vertical one as well. But certainly, there is observations and like I said, playing with those variables. So whether it's like adding in stimulation of the vestibular system with head rotations, or removing vision, or kind of, again, compromising vision with eye movements, or looking at various things and just seeing if they can even maintain balance, playing with the base support, like basic kind of things we've learned. It's just, when you're looking at an ACL, instead of just doing eyes open, eyes closed, what about adding in saccades? Or what about adding in horizontal head rotations or gaze stability? Can they maintain balance during that? Or like it said, the drop jump is more, again, an observation where it can be hard to quantify things without, spending an arm and a leg to get the kind of equipment to do it. But there's definitely more and more stuff coming out, different apps, to be able to quantify things that hopefully in the future are going to be more accessible. That's one of the goals for my education platform, is to create accessibility to some of these things, because it should be more common practice. It's just, again, like that kind of tech is usually reserved for the scientists that implement studies, and then we read these studies and then it's not accessible to use in clinic. So there's a couple of different force platforms that are a little more budget friendly. Again, there's still a bigger purchase, but it is something that is valuable to have to then present to a patient and then show progress in. Again, even in the perception of progress, it's, doing better at something and you just know you did. You could video it on your phone to get that observation, store that observation, so when you reevaluate next time, you can see the difference, or if it's not changed. Also, like symptom reporting is that if they get dizzy, for example, if it is a concussion, or fatigued, or headache, that kind of stuff being generated is also helpful to record. Obviously, like lots of different ways that you can create something that you can track. But it does take a little bit extra work, whether it is acquiring different equipment, or whether it's, storing a library of videos in the patient's file, depending on if you have digital EMR. So it really depends. That's a great question. I think that's a huge gap that needs to be filled.
Yeah, there's space for it, I think. But another thing that you mentioned during your outline of what you're looking at is biomechanics, and the importance of biomechanics in terms of your evaluation. Now, that's something that's taken a bit of a beating in the last few years in terms of how important is biomechanics. And you're not only an athletic therapist, you're not only a physiotherapist, but you're someone who is quite an active individual. You love your own training as well, so I'm sure that you appreciate that movement is more so between goalposts, and it's not the golf hole. It's between two elements. So how important is biomechanics, and how important is perfect movement for you?
I think the definition of biomechanics is very subjective. And I think the way that it's been perceived within our profession and kind of peripheral to our profession is it's about alignment. It's about like perfect angles. Like I'm talking more so about the ability to like control, like just like constrain it and be able to like land a drop jump. It's not about landing with the perfect like shin angle or something. It's more so about coordination of movement. Do people fall out of movement? Say with like tandem gait, are they like swinging their arms up in the air? Like that's coordination, and precision and rhythm and things like that, that again are, it's not about like perfect symmetry all the time, because I don't believe that anyone's perfect symmetrical. I just think that people consider, or even like when I had this conversation about like motor control, people think motor control means like constraining everything. I'm like, no, motor control is actually about like engaging with the world and allowing movement to be free, but like having almost it's like controlling kind of within a very like a level of variability. So it's, there's ends of the spectrum where biomechanics can be completely off and you really need to intervene because there's either a lack of range of motion or there's like too much range of motion happening. But there's kind of a sweet spot in between. But like I said, even from left to right, like I have terrible knee mechanics. Like I have a previous ACL tear. I'm that person who's like, I have the worst like female mechanics, we want to call it that has traditionally been criticized and evaluated and said that's the major cause of ACL tears. And now they're bridging away from that. But it's like, if I can't even land a 30 centimeter drop jump without swinging my arms up in the air and like doing that's what I mean by biomechanics. So that's something that you can observe, you can video, even with certain like tests that are, maybe we talked about the agility pattern or a designated distance of say tandem walking, you can time that. So you can look at like speed of things and how efficient people are. I think that's another point of biomechanics is efficiency across movement and evolving movement. So it's consistency amongst that variability where we don't lose control after one rep of something. So yeah, I think if that makes any sense, I hope it does. That I don't measure, like I don't really use my goniometer very often, if that's what we're talking about.
No, you're not using the Xbox Connect infrared camera to judge everyone's joint angles and make sure that they're moving at a perfect 30-degree abduction or something. Yeah.
No.
Okay. Now you mentioned there as well, motor control, and you yourself have a previous ACL tear. And again, this is something that we touched on right before we hit record on how motor control and biomechanics changes so much after something like an ACL operation or a labral operation, knee op, ankle, whatever it might be. Can you maybe explain to us, one, why it is that our movement patterns change, or what are some of the underlying ideas or mechanisms behind why there is that change that occurs? And two, why this sort of neurosport rehabilitation is important to restore long-term functioning movement patterns?
Yeah, of course. That's a great series of questions. So first, I guess, addressing like post-operatively. So a great example is kind of, an athlete who has had years and years of training, has a surgery to repair, let's say a meniscus or something, is off sport for a number of months. Okay. So now they've been removed from the environment that they're used to training in. This was exceptionally interesting during the pandemic when sports were like completely off and people were kind of away from sport in general without injury, because I found that these same kind of perceptual mechanisms were sort of rusty. And so the exposures had been limited, right? So now we have a situation where those chaotic, kind of constantly evolving environments, they're just not, and you talked about this earlier, like being around a dynamic situation with multiple players in the field, lots of moving parts, the atmosphere, like we're just removed from that. So that's kind of, the pandemic is an extreme example of that. But imagine being that athlete then that's in that situation now, recovering from surgery and trying to like reintroduce themselves to sport. And I had an example of a goalie who was like, it just feels like my brain was like detached from my body and I didn't know how to move. Like it was very strange for someone who's been in a sport for over 10 years of more elite training. And so I almost think of it sometimes like when you hit the factory reset, like in your cell phone, and it just sort of like resets all your passwords, and then you're like, get rid of all your good, like details of your apps. And you're like, oh, I have to reestablish everything again. So it's almost, and my advisor and I have talked about this with concussion as well, where it's like kind of hitting that reset button on some of your neurological mechanisms or like trained skills. And you just kind of have to reintroduce them progressively and kind of in that dose response of, how we introduce rehab again. But that chaos is really important to reintegrate. And it's just establishing, like, whether it's, again, that peripheral disconnect of, when you're after surgery, you're having disruption of some of those nerves, right? So the efficiency of communication now between the brain and that joint is a little bit affected from whether it's mechanoreceptors, joint receptors, proprioceptors, your force, tension relationships with like Golgi tendon organs and muscle spindles, like that's all been somewhat disrupted by surgery. So now it's like we have to reestablish, and also you're having an immobile kind of period after the fact, right? So you're not able to actually do anything for a little while. Yeah. So there's now this, and you have swelling and all those other components, say for a knee, just adding in those other factors to consider that now there's all these things affecting the efficiency of that neural connect. So the nerves can fire, but it's like, they still kind of have to relearn. There's a pattern of motor learning that has to occur there. And when I start to sort of segue into the second part of your question, why it's so important then to reconnect that is because we use all those sensory variables to like upregulate and assist with those mechanisms restoring themselves. So whether it's utilizing vision, I know some of the clinicians in the courses I teach, one of them said like their husband had a knee replacement and he was on a stationary bike and he was just doing saccades because he's a cyclist. And even a cyclist, they have to be able to look around comfortably on their bike. So he's like started those mechanisms early of just like re-engaging with the world a little bit, even though limited to do it kind of in the real world at that moment. So there's like little ways that you can start to reintegrate and even there's some really interesting work coming out with, and again, this is my area, but the ACL research crew with like using things like neuromuscular stimulation to reignite those nerves a little bit and reconnect. But they also talk about upregulating things like visual cues instead of focusing on proprioceptive cues. So as we said, like using the other sensory mechanisms to sort of connect those things together, because as I said, whether you're walking down the street or you're on like a rugby pitch, you have to be able to process information from your environment to move well and successfully. So I hope that answers both parts of that question of why it's important. We can't really tease them apart, right? So if we just focused on restoring range of motion and strength, and then we throw someone in a sport competition scenario, we're missing the mark on reestablishing all those kind of perception action mechanisms.
You say that we can't tease it apart, but I have definitely had patients in clinic where I can see that they haven't had that at all as part of their rehabilitation.
Well, we can tease it apart, but it shouldn't be teased apart. Maybe as well. I should have phrased that.
Yeah. So how is it that we can maybe add this into our normal repertoire with patients? Are there any sort of basic exercises? Now, it's never going to be a cookie cutter approach with one size fits all, of course, but there are any basic elements that someone can add into their rehabilitation program so that they can start implementing these things with patients when they get back into clinic on a Monday morning?
Yeah, so I'll use an example of something that's actually pretty well researched, and I know is continuing to be researched, is like a pretty standard balance assessment. So, like your Y balance test, the reaching anterior, like posterior, medial, and posterior lateral reaching task. It's like part of the FMS, the functional movement screen, and now it's kind of evolved into some other things. And there's a study, I forget what year, I want to say 2018, of like Verschuren et al. That looked at a reactive YBT. and they used the fit lights kind of as targets on that YBT. So they used it as a reactive mechanism of measuring balance control during a reactive scenario. So it's just now, instead of using a simple assessment like that, or your star balance excursion is probably a little more familiar even than the Y balance test, but using, even like I said, those DIY apps to simulate like a visual cue to initiate an action to a meaningful target is connecting that vision to action. Now we're doing a visual motor task. That is connecting the perceptual processes of vision in the brain to recognize a specific target. Say if it's a blue cone, a yellow cone, and a red cone, it's like whenever the color is displayed, then they have to reach for that corresponding target. You take a simple task like that, you can even just use simple arrows. And honestly, people have used PowerPoint presentations. They don't even use apps sometimes. It's simple to DIY, but if you do have some tech that you could implement, it's like, especially if your clinic has it, you really should be using it for more than, and that's where those things come into play. And sometimes I see that tech being used where they're just using like, anything is a target and there's no meaning or kind of like meaningful rule associated with the stimulus. And it's such a waste because it's literally just like a visual motor, like arbitrary thing of just react to whatever, and it doesn't matter. But if all of a sudden you're doing a task and something all of a sudden is even just, sometimes I use just a simple square setup where it's multi-directional pivoting. But when I have certain, like say with the fit lights, I use like green is right foot and purple is left foot. So now they have to extinguish those lights with different feet based on what's presented. And so it changes the way they have to react to it. Or even like some of the goalies I work with, they, bounce a ball on the wall and they just like practice their reaction time. And it's like, sometimes I just stand there and I call out like left hand, right hand, and they have to switch hands and catch the ball with different hands. It just stimulates that like quick, it's the perception is the interpretation of something. And that's what is a big difference. And that's a very, very simple way to start implementing it in like, that's just a couple of examples, but you could take it and go with that in any direction. And that's what I try to encourage other clinicians to do is like, don't reinvent the wheel and follow me exactly of what I present. It's like, you already do things. Just take these little, just refine it a little bit and add some other variables, like the layering that you talked about kind of at the start.
Yeah. It's basically adding dual tasking or multitasking into the individual's program or into the individual exercises. Even something as simple as doing their sort of one leg diver, if they're then having to come up and catch a ball, or do the diver exercise with their eyes closed, is already going to be an element of utilizing more proprioception or utilizing more visual balance or what have you. So of these aspects, which would you say in your experience is or are some of the most underdiagnosed and underdeveloped areas in rehabilitation, would you say?
I would say that, and I guess it depends on the context, is like, if I, say one sensory thing and, for a certain person that maybe has low functioning of that sensory system, it's kind of hard to say whether that's true or not. But I would say, like, just from the research I do, we look at vision very in depth. And so there's lots of ways that, and because vision is so ingrained in our brain too, it's like, honestly, they don't even understand entirely how we process vision at the higher levels yet, especially kind of into the frontal lobe and cognitive areas. But from the standpoint of how simple it is to apply some of those, like the cognitive motor integration of like those rules, or using a cue to simulate a decision. It's like, that's the kind of stuff that I think is so simple to do. And the research is there to support it all. And it's just, it doesn't somehow connect entirely into how we are taught things, which has like really been eye-opening to me as I read like fundamental papers that have been around since the 60s. And I'm like, well, why isn't this? And there are even some researchers who are like physical therapists who have been around for a long time, and they've been promoting how, movement is generated from this interaction of the task, the environment, and the person. But how we actually implement that is so, I think, undervalued. And I think that it's either like an arms race of technology of how to actually do it, or thinking you can't do it because you don't have the technology. Whereas there's ways that you can simply do it with whatever you have, really. So I would say even things like auditory and just like stimulation in the environment, or like recreating things. One of the things I recently got in the clinic was a projector. So I now can project like point of view videos, say like an ice hockey player on the ice, even as simple as like someone shopping in a store. Like I just all of a sudden the visual stimulation of that, we can like recreate those environments and do things. But from simple tasks, even as they were talking about like a lower extremity rehab, simple as like the reaching task of single like just reaching balance that can happen very early, all the way to higher level like agility and movement and obstacle avoidance or plyometrics. You can integrate these visual cues, like I said, auditory cues, anything that really is appropriate for the person too, right? Because that's kind of that other central component is like, what are that person's capabilities? What is their functioning like? And that's what you have to design it around. That's why the cookie cutter process doesn't exist. We can simulate environments, but then it's all about who's that person in that environment now, that we have to consider all the things that could influence their movement. So certainly it gets like more confusing the more you get into it, I feel like. And kind of that's where I'm at with my knowledge. I feel like it's sort of that cliche of the more you learn, the less you know.
Yeah.
Which is a good and bad thing.
But for me, that's what makes it all the more interesting, because it seems like you just get more and more lost in the weeds. But even though you're getting lost, it's an interesting time and there's so much to discover. And again, one of the things that I mentioned before we jumped on is one of the big discussions I tend to have with my interns, this utilization of double tasking and why it is that our body just freaks out almost and forgets how to use itself, whether it's post-op or if someone's had a really, really bad ankle sprain and they just feel completely off balance all the time. Do you ever find that, let's say if we take central disturbance, let's say if we take a concussion patient, it's never a straightforward rehab process, unfortunately. If it was, oh God, wouldn't life be easy?
That's what I say all the time.
Yeah. But how often do you find that there are multiple sensory systems that are plagued with deficits, shall we say?
Mm-hmm. All the time. I think too, my clinical practice is the kind of stop that's probably like fourth or fifth on the list for a lot of people. And it's becoming more so now that we are coming out of the pandemic more. I'm getting more kind of the initial contact with people, but I've definitely had some people come out of the woodwork that are 2 to 5 years after an injury or something. And so that's when things get complex too. But in the initial, like we have all our clinical domains and they talk about these kind of concussion phenotypes of predominant symptoms of being like headache or vestibular or vision or autonomic. And so I always find like, yeah, there's probably one area that is like predominantly affecting things, but again, you can't tease them apart. So there's always going to be influences of other things. Because of one system driving a dysfunction in the other. So whether it's like a vestibular ocular dysfunction driving up the autonomic sensitivity and exercise intolerance, like that stuff all plays off each other. And usually the autonomic system is kind of one of the under investigated areas because of the predominant thing that's overriding. It's like people forget that, you can get up from lying and your heart rate can jump over 120 beats per minute. Instead of just, your blood pressure. Traditionally, we think of hypotension, but tachycardia is very possible too, but it can be stimulated because of just the change in head position or just bending over to tie your shoes. Like, what's that person's heart rate? So often I'm like doing kind of 2 assessments at the same time in my practice anyways, now that I understand sort of how everything integrates together. As you said, it's so complex that it almost gets more complex the more you learn about it, which again, is a great thing because it's constantly evolving and we learn so much more about it all the time. But all those variables have to be considered all the time, because if you don't, like from the base, if you kind of have these like 5 clinical domains, if you progress 4 of them, but one of them is still lagging, you're never going to cross the finish line of recovery. So if you get, tolerance for eye movements and head movement, but then you haven't really worked on coordination or exercise tolerance of, like, let's say of actual training, not just like on a stationary bike or a treadmill, of, tolerating a squat, a deadlift, like those movements, all of a sudden you're running into barriers of, oh, this person can't return to exercise. It's like, well, we can't get there until we determine the cause of that. So there's lots of things there for sure that influence the outcomes and recovery time. And that's one of the areas that have really kind of flourished in my practice of, I think my experiences from a more athletic background and sort of even having some strength and conditioning components and mixing it with this neurological piece, is that sometimes there's people that are kind of stronger in either camp, but then the connect between the two doesn't always get there. So, getting someone back to strength and conditioning is different than just doing vestibular rehab. So a traditional vestibular rehab is, moving your head and tolerating that, or bending forward, tolerating that. But then we add load to that. What does that then look like? So they've been really starting to move down that path of connecting all those dots together, which it's been great actually to see some athletes really excel in that process. But it's frustrating and it takes time, and it's not something that is as quick as what a lot of the sort of, I guess, expectations are for recovery in some contexts. So there's no real timeline on that, unfortunately, right now.
No, absolutely not. And yeah, what you mentioned there of, the 5 general types, if you've got 4 of them doing A-OK, but you haven't addressed that last one, you're not going to cross the finish line. It's that was where I wanted to lean towards, of part of the reason that it's not a straightforward journey is there are sometimes particular elements that are slowing down or preventing the progress of other areas for improvement. And I've had this very recently, actually, with someone who was able to begin to do some aerobic training, someone who comes from elite top sport background, and was all of a sudden unable to even row 500 meters without headaches, dizziness, having to lie down, nausea, and all the rest of it. And this is someone who, prior to that, not 3-4 months before, was, scholarship in the States for rowing and all the rest of it, and in the gym as part of that scholarship 4 or 5 days a week on top of their normal training. And now 500 meters and they're beat. And it's one of those things where, as you mentioned, the expectation for their rehabilitation was, I've had injuries before, I'm going to overcome it, it will be grand. And there you are, a month and a half later, and you're still slowly building things back up, step by step by step. But one of the aspects to concussion rehabilitation, or one of the things that can prevent the progress, even if we come away from just the neurological side of it, is the musculoskeletal side of it. Let's say if they've had a whiplash or something with whatever it was that had caused the concussion in the first place, how does that then factor into it? How can we then pick up on it in clinic, and how can we take that into our rehab programs?
Yeah, so obviously, like, considering that your neck is kind of balancing this bowling ball all day, and then in the mechanism, that deceleration, it's your neck that really absorbs a lot of that force as well. So in most mechanisms anyways, the neck is a huge consideration. And think of it as, I think I used a submarine analogy once, but it was sort of like the periscope is your vision. It basically kind of guides which directions you choose to go and kind of information about what's going on in the surroundings. Your vestibular system, your compass, detecting the change as you change, like, you change steering, it picks up that acceleration in the direction that you're now going in. And then it's really the neck that's kind of the propeller of like directing all this where to go. And so what can happen is if there's any dysfunction amongst those three systems, it can drive up like autonomics. It can drive up all those symptoms you spoke of. And it also can, like, and this is again a hypothesis more so than maybe a research-based idea, but you would think that if there's a dysfunction of maybe binocular vision, there's a discrepancy there, that what is the brain then going to use as a defense mechanism to control, like, okay, our vision and our vestibular system, maybe they're not working well together. The neck is going to stiffen up in response to that to control the head in space and constrain it a little bit. So the idea that the neck is always the cause of the stiffness from maybe an injury to the neck, yes, that could be true, but I always think of it kind of as a chicken or the egg scenario of like the neck is an injury to the neck that is causing this flare up, or is it because like the vestibular system and the visual system aren't connecting well? And now we're getting this reflexive tone control. You think of other neuromuscular disorders where we get tone, that like a motor neuron lesion causes tone. So if you think it can happen that way, then on a certain degree of a spectrum, you could think that a response could happen as a top-down mechanism. It's how we maintain balance control. So if you think of if the vestibular system's like, oh shoot, we don't know where we are. If you turn too quick and it's like, I always think of like Tokyo Drift. It's just like a slow to catch on of, molasses, like thinking of like you turn too quickly and you get this whoosh. It's gonna like reflexively tighten up that SCM and the upper fiber trap and be like, holy, control the head, like figure it out. So, we bend over, our rector spinae engaged to make sure we don't fall over. You'd think that happens potentially with the neck. So like I said, it's not like I know this from a evidence-based, literature, but kind of so, I think, but it's a theory that is sort of built upon the fundamentals of what I know about postural control and how the brain can influence it reflexively. The medial vestibular spinal tract influences all the neck musculature and engaging the postural writing and all that stuff. So if you think about those connections, then definitely the neck is a huge player because, again, you can't tease them apart. No. I think sometimes people tease them apart too much and maybe don't integrate them enough because even in vestibular rehab, there's just like a lot of neck stimulation and then the neck gets sore and people are like, oh, now I have symptoms because I was rotating my neck back and forth for 10 minutes or their head back and forth. And so I actually sometimes work with more whole body motion to build up, say, gaze stability tolerance instead of the traditional head turning to the metronome thing right off the hop because it irritates people. So I kind of went on a tangent there, but I hope that makes sense with that scenario.
It's funny you mention the neck movements right at the end because swimming was one of the things that then started to get the neck to tighten up a little bit more because obviously when you swim you're going to have these particular patterns of movement as well in the neck, and that was something that we were also beginning to see a little bit of a frequent thing that was kind of cropping up there. So it's interesting to put that spin to it. Absolutely. Yeah, I think then that kind of brings us back to the work that you've been doing. Like you say, it's an educated hypothesis based on not only the research that you've been doing for your PhD, but also the work that you've been doing in clinic and anything that you've looked up that's gone towards your work in clinic outside of the PhD itself. So what do you think is sort of the next step for the work that you're doing? Where do you want it to go from where it is now? What's the way forward?
I think, well, it's already kind of being done. I know there's groups like University of Pittsburgh and like I said, even the ACL, like the Ohio State groups, they're already looking at how perception action integration connects to ACL recovery, to concussion recovery. If you've ever read any of Sean Eagle's papers, literally talking about a perception action approach to this. it's already been there, and there's tons of like just sport and coaching literature on how athletes have superior perceptual skills. And so if we consider an athlete to have those skills, then we should expect them to achieve that level of skill upon regaining it or restoring it in recovery. And so I guess like the next phase I continue to finish off my dissertation is like looking at how we evaluate athletes with this higher level of training, so that when they are recovering from something, we're actually holding them maybe a little bit above sort of an untrained individual and kind of what we're considering. So whether it's we're looking at dynamic visual acuity as one of our measures. And I presented this at like ACSM and a couple other platforms, but we have found, and even in the original investigator, Dr. Christine Dalton, she's published a paper showing that athletes are more superior at the task compared to the controls and the video gamers that they had in other groups. So what's been interesting is like, now that we know that, we can kind of identify that maybe their dysfunction almost can kind of look like an untrained individual. So we actually have to really be careful of how we evaluate. And maybe that the normative values we hold an athlete to for some things actually should be a little bit higher. There's been other studies that have looked at that with reaction time and other things. But certainly, like, I want to explore the concepts that I look at with sort of like the dual tasking and attention, because really athletes are just really good at allocating their attention. That's what all this boils down to. And you've sort of alluded to it a couple of times where you talk about like, when you're injured, it's like your attention then is now distracted by that injury because pain, discomfort, whatever, like lack of mobility. It's like all of a sudden now you're focused more on that one joint or something that's just like more bothersome. And so when we restore that, and then they can allocate their attention to the skills that they need to perform and the environments they need to be in, that's when the efficiency returns. And so anything can disrupt that attention, like motor skills themselves eat up a piece of that pie, right? It's like visual skills take that piece of the pie. Any environmental stimuli, they have to tend between and switch their attention between, use that up. It's just athletes are like more trained in the skills they need to perform, but they don't think about them, right? They're not thinking about dribbling a football. That's rudimentary. That's not on their mind. They're thinking about 3 moves past the defender in front of them of what they're going to do with that ball. So the cool thing is that some of the work we're doing is looking into this stuff, and the next steps for it, I want to explore things. As you mentioned, I work with para athletes, and there's not a lot of research with para athletes for concussion and management. And there's obviously discrepancies in kind of what's available for upright or able-bodied athletes. So apologize, my dog is joining the podcast quickly here. And so
welcome
what
guest.
What I'd really like to do though is be able to investigate some of these things to apply to other types of athletes, and make sure that it's kind of that we have inclusive protocols for things, because a lot of it is focused on sort of our elite level able-bodied athlete, that there's other things to consider with a para athlete, that, and depending on the disability that they have, maybe it's a congenital condition, maybe it's an acquired injury, there's various things we need to look at there. So that affects that brain to body connection. And so we need to understand that much better than we currently do, as those sports only get bigger, faster, stronger. I think it's a huge and really important next phase of looking at things.
Interesting. I'm looking forward to how that goes. Going back to what you were saying about the athletes, and essentially the processing power that it requires when injured compared to when they're firing on all cylinders. It's almost as though, if we think of it like a CPU in a laptop, they have X amount of thread counts to where they allocate the data, the piping that the data can go through. And when we've got an injury, it takes almost all of our threads that we can filter the information along to do that. And then when we're firing on all cylinders, it only takes 1 or 2. It then leaves a lot of room for our internal computers, that thing inside your dome, to then be able to make better judgments on the field. And I think that also comes into re-injury rates as well. People then returning to sport too soon. No, if
Absolutely.
yeah, their processing power goes the complete wrong way of focusing on the knee, or where again, if we say it takes 5% normally, and then because they're so fixated on the knee, even though they're in the return to sport phase, it's taking more like 30 or 40%. That is not leaving a lot of computer power to go towards looking at what else is happening on the field in terms of other players, in terms of the crowd, in terms of the field itself.
Exactly.
How does that, yeah. How does that factor into rehab for you guys?
Oh, that's all the stuff that kind of we've discussed. And I think it kind of brings everything full circle is growing body literature on this. And really the mechanisms as to exactly why aren't entirely clear. But there's lots of researchers looking into this. And one of those, like I mentioned, the Sean Eagle paper is talking about that perception action approach and musculoskeletal re-injury risk after concussion. And there's a really nice paper by Cross in 2015 that sort of catalyzed my thought process for my PhD, but I was looking at the rugby union players and re-injury risks, but also time spent in that return to sport protocol. They spent like 24 hours in each one. So you imagine that if 24 hours kind of through each phase and then they're returning next Saturday, it's like, can you actually say that they've restored the capacity? So that capacity, I always think of as like a pie chart of like, certain slivers go allocated to different parts. And even if it's just a confidence thing of, that's why I think with even ACL, it's like they also consider the psychosocial aspects now as being hugely important because confidence level. Because now when you're not confident, you're in your head, steals a bit of your attention. Yeah. So it's percentages, right, of that attention that in high level elite sport make massive differences. And that's why I always say to an athlete, do you want your 75% on the field or, someone who's maybe not as skilled as you, they're 100? And do you think you can go back now and be like contribute to your team's success? That's kind of when I have to have those hard conversations. I sort of relate it back to this capacity level of, and that's where we start to layer in rehab as we progress. It becomes, like I said, we smash those the silos and we integrate things like vision and reaction time, agility, speed, power, cognition. All those things get put into play to try and mimic as best we can in the environment, obviously, we have. To mimic a sport competition. And so the best thing though, is the time spent in the actual environment. So a lot of the athletes that I work with are progressively building up their tolerance for practice, for just being around the competition, whether it's field or it's ice, while everyone else, like you said, is moving around them. Sometimes that can be really overstimulating. But just being present there and getting used to all the components of those environments are really important. And then slowly building up like the dual tasking and then kind of integrating into those, like the way the phases that are laid out for return to sport is being kind of this, you start to do sport specific skills and then you mix in a non-contact practice and then you do a contact practice. It's like, I think we should be having more time spent in those latter phases to be really confident about an athlete's capabilities going back and the capacity to do that. Because evaluating that on one practice, depending on the practice, like, is it a captain's run or is it a higher intensity practice? You know what I mean? So I think it has to be like 3 to 5 practices that have to be really good. But unfortunately, we don't really have a good measure of that capacity. There's lots of different ways to look at it. And I think that's what we have to do is be really thorough and kind of looking at each dimension and having something to track it. One of the ways, I know you're talking about kind of tracking multiple things, is I use NeuroTracker as one of the tools in clinic as well. And it's a multiple object tracking task in 3D. And we build that progressively up to doing with dual tasking and such as well. But it's something we can monitor like a speed threshold of the task. It's basically it's like that Pong game, but with like 8 spheres that you have to track a select few of them. So it's really complex and it's not something you can cheat at. And so they use that in elite soccer and like rugby and various sports that I think it's even, I don't know if it's Manchester or Chelsea that uses it, but one of the, elite football teams uses it with their players just as a cognitive training tool. So that's something too that you could evaluate. But again, it's another thing to add, another objective piece, but it's another product thing that you can acquire. So that's where I think it's the more we get into this stuff, and that's kind of why my clinic is sort of niche down into it, is because not everybody can afford to kind of be everything. And I think the future of what rehab and clinics is going to look like, instead of this generalization of everything, it's like people are going to start niching in and be really, really good at sort of working in specific areas. And that's going to be kind of a trend, I think, moving forward.
Moving forward. Yeah. Nice. Like you said, I think that does bring us back full circle. If you had 2 or 3 tips maybe to give to someone that wants to get more involved in this aspect of rehabilitation or even research, because I know that can be quite a daunting thing for people. And you mentioned before we got started, you didn't imagine you'd be doing your PhD, yet here you are, hopefully, touch wood, almost finishing up, right? Yeah. If you've got maybe 2 or 3 tips to give to the listeners there.
Yeah. Like obviously I'm not going to recommend that everybody goes and jumps into a doctorate to learn all of this themselves. I think like certainly exploring literature, and that's an affordance that I have as being a part of an institution, of having open access to a lot of things, and that's not always available to the general public. So it's sometimes hard to even access papers to read them. But I think like even just some of the, like, there's continued education courses out there. I lead a course. I know there's others that kind of have this sort of motor learning, motor control type stuff starting to emerge. Another great course is ACL Study Day. I love that stuff yearly that they put out with that for more orthopedic stuff. It's just like opening your ears and your eyes to kind of the world media and like being really critical about that. And it's definitely hard these days to navigate. Like, I don't know if I have great tips, because, sometimes I see stuff like I recommend going on like social media and checking out some accounts, but then it's like, sometimes I see things I don't like either. So it's really tough to discriminate, like to really criticize and know that what you're absorbing is accurate. But I think it's sort of a blend of just dabbling in your own experience. And a lot of this stuff is what we did learn. It's just a different perspective and lens on it. And so I think it's, some people always want to jump course to course to course and just keep learning and learning. It's like, sometimes you just got to get down in it and just be good at what you've learned for a while, and just start to notice things, like start to observe patients and clients that you see, and any of these nuances, just experiment a little and see kind of what happens. There's no harm in, playing with some of these variables and just seeing, if I change vision, what does that look like? If I add some different movement components, what does that look like? Certainly, like I mentioned, the apps, some of them are more DIY to kind of start doing that with. Is switched on training is one of my favorite. I work with Brett a little bit with that one, and that's been a really great app that I've used for home programming, through like just in clinic, lots of different ways. But just starting to get creative, I think, and thinking outside the box. If
Nice.
as broad, as vague as that sounds. But certainly like some of the papers I mentioned. Yeah. It's just, I know, like, and I don't want to, toot my own horn here, but like certainly the course I created was basically to help translate a lot of the complexities of the things that I've taken years to learn into a couple months. So I certainly, and that's how it started. Honestly, someone was like, the pandemic hit, there was nothing really going on, everything shut down. And it was sort of like, hey, do you want to teach us kind of some stuff that, and so I decided to do it, and it evolved into what it is. And it's been really great. And it's been really rewarding to see clinicians start to connect these ideas together, just like I said, weave it into their practice that they're already doing, rather than try to reinvent their process. Just like refining and tweaking some things.
And that's something that we haven't spoken about at all. So I know it's getting late in the evening there for you as well. If you could maybe take a couple minutes just to tell us about that course as well, because I know there's also multiple modules to it. So maybe if you can give us a brief outline as to what that is, and yeah, if people are interested, where they can find it and where they can check that out.
Yeah, so appreciate you giving me the time to I'm not the greatest at marketing. So yeah, I created clinical neurosport education, or CNS ed, in at the beginning of the pandemic, when all of a sudden I realized I had all this time on my hands, to kind of start connecting these ideas to clinicians who were interested in it. And so it started out with a group of physical therapists and athletic therapists on Zoom, and now it's on the CNS Ed website. So it's just like the acronym is just CNS Ed. You can look that up. And the primary, like the flagship course, is the Athlete Brain Rehab course, or RX course. And so essentially it's grown into kind of this super course of each module kind of covers the main domains that we've discussed even through this podcast, of just understanding how athletes like utilize vision and attention to perform, and how injury and dysfunction or miscommunication kind of affects that process from kind of a neuroanatomy perspective, and how it integrates with movement and coordination of movement. And then we sort of talk about all the sensory components, is like vestibulo-ocular motor and the neck and autonomic system contributions. And then we sort of blend everything into balance, control, movement, coordination, speed, agility, and sort of build it up to the end of like layering it on through the entire course, to building up to how we would get someone to return back. And sort of all the tips and tricks and equipment that I use along the way is featured throughout. And so a lot of those strategies that I've talked about today are included in that. And it's really grown into something that I'm really proud of. So I've had a few more clinicians through it now, that it's sort of a little more validated, and it's a lot more organized than when it started. So you can definitely check out the website. Even like you can kind of go through thriveneurosport.ca is my main website, and it links right through to the course platform for that. But everything is online. So now it's a little more accessible kind of to globally, to allow more people to enjoy it. So yeah, it's been really fun to do that as well.
Right. And where can people find you online as well, on socials, if they wanted to catch up with what you're doing?
Yeah, I post a lot of content there too. So that's a good place if you want to pick up some tips, I guess. At Thrive Neurosport is my Instagram. Twitter, I think I'm different. Oh my goodness, I have to actually check my Twitter. It's at @KatieMitch_ATPT is my Twitter. Not as active on there, but Instagram for sure is probably the primary place to find me.
Fair. All right, cool. So at Thrive Neurosport on the Insta, and thriveneurosport.ca. And then not only can they find you there, but they can also find the online course as well.
Mm-hmm. Yes, definitely.
Great. Well, listen, Katie, thank you very much. Really appreciate you giving up your evening to have a little bit of a chat with us. And yeah, we'll catch you around soon.
Yeah, thank you so much for having me.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time, peace.